Before we move on to the second session, please be reminded that masterclass tracks 4, 5, 6, 7 are progressing today at the Connect room, that is one level below. Those who have registered prior, please proceed to those sessions. Our next session, Young Internist Lens, provides a platform for emerging specialists to share their experiences, insights, and innovations in internal medicine. May I invite Dr. Chaminda Kottage and Dr. Nandana Dikmadugoda to chair this session. Please join me in giving them a warm welcome.
Good morning. Welcome to the second session of the second day of SIMCON 2025 session. As the tradition of the Sri Lanka College of Internal Medicine, we are introducing every year new segment. This year we have put a new segment called Young Internist Lens. You will see the academic world through the young internist. So without further delay, I will introduce our first speaker. So this is the young internist lens. So I will introduce the youngest professor in medicine in Sri Lanka, Professor Chamara Dalugama. It's an honor for me to introduce him. He's the professor in medicine, Faculty of Medicine, University of Peradeniya. Over to you, Prof. Chamara Dalugama.
Very good morning to you all, and thank you very much for that introduction, and President Sir and the Council of Sri Lanka College of Internal Medicine. Thank you very much for inviting me for this segment, and it's indeed a great pleasure to be here. So without taking much time, let's dive into our case. And I've themed this talk today as a multi-system masquerade, because when you go through the story of this patient, you will realize that initially this looks very deceptively simple, but then it will unravel into one of the very complex multi-systemic diagnostic challenge. So let's dive into the case. So let me introduce my patient, Mr. AB. He's a 52-year-old father of 2 children, a banker by profession, and he's from Kandy. And he presents with gradually worsening exertional shortness of breath over past 1 month. So further looking into his story, his symptoms, NYHA class 2 to 3 symptoms, and he has orthopnea, paroxysmal nocturnal dyspnea, and on and off palpitations. And over the same period, he was complaining of an on and off productive cough for 1 month with wheezing, but responded poorly to antibiotics and inhalers given by the GP. So 2 weeks into his respiratory symptoms or the cardiac symptoms, he experienced diarrheal stools, 6 to 8 episodes a day, large amounts, watery with mucus and blood. And this was associated with lower abdominal pain and 1 to 2 episodes of nocturnal diarrhea as well. And during the same period, he complained of significant loss of appetite and significant loss of weight. And he had generalized malaise and fatigue. So with that acute story in the background, he has type 2 diabetes, which was diagnosed 1 year back, and he was started on metformin and glycoside. He had a fairly good glycemic control, but over the last 3 months, he noted that his urine is frothy, and also his bilateral lower limbs felt numb over the same period. And he's a non-smoker, occasional ethanol consumer, is married, father of 2 daughters, no recreational drugs or any high-risk behaviors. Right, so when you look at this story, it's quite a mix, right? So he has still we add the history. So he has a history suggestive of, say, heart failure, and there is some gut involvement in the form of large bowel type of diarrhea, and he has presumably a renal involvement in the form of proteinuria, and probably a peripheral neuropathy in the background of diabetes mellitus diagnosed 1 year back with good control. Right, so this is going to be a very interactive session. So I want the audience to help me in unraveling this mysterious case. Right, so before going to the first question, let me set the philosophy for this interaction. So these 2 people, the one into your left is Occam, The plurality must never be posited without necessity. Is there a unifying diagnosis which can explain all his symptoms? Or, in contrast, Hickham, a patient can have many diseases as they please. So in which team are you? Who's for Hickham and who's for Hickham? Right, so let's go to the first question based on the history. Right, so it's quite a packed slide, so let me read it for you, take your time. And then there is a QR code displayed in either side of the presentation, so you can scan the QR code, and then I think you did a similar thing yesterday as well. So take your time, scan the QR code, and give your answer. So meanwhile, let me read the answers as well. So just with the history of this patient, what do you think is most likely diagnosis? Is it carcinoid syndrome with fibrotic right-sided valvopathy and secretory diarrhea? Is it sarcoidosis with granulomatous cardiomyopathy with colonic infiltration? Is it HIV infection-related cardiomyopathy with chronic diarrhea and peripheral neuropathy? Systemic AL amyloidosis with cardiac, renal, or enteric involvement? And tuberculosis with constrictive pericarditis and ileocholic involvement? And diabetic cardiomyopathy with congestive enteropathy? Right, so there can be many more differentials given the broad history, but I have taken these 6 possibilities and we'll see how we vote on this. Let's take another 10 seconds and see, we'll analyze the vote. Right, okay, so we'll go through the votes. So, carcinoid syndrome with fibrotic right-sided valvopathy, one has voted. Yes, it's possible, because in the history he was complaining of some wheezing and there was a cough, and the GP has started some inhalers as well, and then, so likewise, and then moving to sarcoidosis, yes, it's a great masquerade, it can mimic anything. So it can be granulomatous cardiomyopathy with colonic infiltration. And HIV can have a protein of manifestations like HIV enteropathy, HIV cardiomyopathy, HIV can cause peripheral neuropathy. So it is again possible. And vast majority has voted for systemic amyloidosis with cardiac, renal, autonomic, and enteric involvement. So you will see whether you are correct or not with subsequent slides and with the history and investigations. And tuberculosis is, you need to consider tuberculosis, being in an Asian country, being in Sri Lanka. With such symptoms, tuberculosis again coming in one of your top differential diagnoses, and diabetic cardiomyopathy with congestive enteropathy, it's again possible. And also, for Hickham's dictum also, you can consider, I mean, the cardiac issue may be a separate one, and he was started on metformin, and this diarrhea may be related to metformin, something like that, but that comes low in your differentials. Right, so let's move to the examination, keeping this in mind. Right, so there's no right or wrong answer here yet, because we are yet to explore a lot of things in this patient's story. Right, so in the general examination, he's averagely built, this neck, not pale, neither plethoric, and he's not icteric. And in the in your right-hand side, there are large areas of ecchymotic patches, and some of the patches were after the venesection, but some were spontaneous. And in the second picture, it's not very clear, but you can see some hyperpigmented macular lesions in the legs. And there was pitting ankle edema, and it's not a good picture though. There was a loss of hair up to the mid-chin level, suggesting the peripheral neuropathy. And in the left picture, he had a bit of a large tongue, and we could see all the dental indentation on the tongue. Right. So then we'll move to the cardiovascular system examination. His blood pressure is 110/70. Pulse is irregular. JVP is elevated with a positive Kussmaul sign. Apex is palpable in normal position. S3 gallop is present and peripheral edema is present. And on respiratory system examination, on-air saturation is 95%, central trachea, and lung expansion reduced with dull percussion and absent breath sounds in both lower zones. Right, so before we move to the rest of the examination, we'll take the next question. So that is based on your cardiovascular system findings. So just go through the findings once again and then be ready to answer the question. Right. Okay, so which of the following diagnosis best fits this bedside examination picture? So we have restrictive cardiomyopathy, constrictive pericarditis, acute right ventricle infarction, severe tricuspid agitation, and pulmonary hypertension with RV failure. Okay, so it's 100% is going for restrictive cardiomyopathy, but I would say, yes, that's true. But the constrictive pericarditis is something that we find difficult to differentiate from restrictive cardiomyopathy just based on the clinical examination. But yeah, so, okay, right. So, because here the catch would be his apex is palpable. Usually in constrictive pericarditis, we find that apex is difficult to palpate, but in restrictive cardiomyopathy, apex is in normal position, it's palpable, but the positive Kussmaul sign and the elevated JVP can be seen in both constrictive pericarditis and restrictive cardiomyopathy. But I think the audience is biased with the story, and looking at his big ton, you voted for restrictive cardiomyopathy, so that's fine. And then the abdomen, there's mild hepatomegaly. We'll move to the next slide. Yeah, mild hepatomegaly with no free fluid. And nervous system, there was stocking type sensory loss for pain up to the level of mid-shin and absent ankle jerk and loss of joint position sense. Right, so let's move to the investigations. So I have included the main ones that, so the hemoglobin is 10.5 with a normal MCV, platelets 340, WBC 3.4, CRP is 10, ESR is 45, and his creatinine is 155 micromoles per liter. And we traced back his previous creatinine, which was done 1 year back at the time of the diagnosis of diabetes, which was normal. And he had a mild hyponatremia and a hypokalemia, and the UFR showing 3+ protein without an active sediment. There were no red cells or casts. So then further into his investigations, he had low albumin and high globulin, so reversed albumin globulin ratio, normal transaminases, normal bilirubin, INR is 1.4, and LDH, TSH, ferritin, and calcium levels all were normal. And then this is the patient's chest X-ray. I think that confirms our clinical examination. So he had a cardiomegaly with bilateral pleural effusions more in the right side. And then we did a pleural fluid aspirate. And if you quickly go through the aspirate report, you will appreciate that it's a transudate. And the pleural fluid AFB was negative, and ADA, adenosine deaminase levels, were also normal. Right, and then comes to the 2D echo. Right, so we have done the echocardiogram for this patient, which shows an ejection fraction of 31%, a dilated left atrium, a concentric LVH, severely impaired biventricular systolic function, and severe diastolic dysfunction. And then the comment from the echo was possible restrictive cardiomyopathy. Right, so at this point, what would you do? Right, so we have done this many investigations, and we want to confirm the diagnosis. I'm sure you all are thinking about amyloidosis based on your votes, and then based on your the answer to the second question. So what is the next investigation you would like to do for this particular patient? So we'll take the vote again. Right, so we have cardiac MRI, abdominal fat pad biopsy, rectal biopsy, endomyocardial biopsy, and renal biopsy. So that's a good question, I believe, because there is a heterogeneity in the answers at least. Okay, so those who have voted for cardiac MRI. Agree. So amyloidosis, Cardiac MRI would give you the fancy diagnosis. There'll be very nice imaging. But whether it is going to help with your management is the question. And to start with, this patient came to Peradeniya Hospital, and we are not in a position to offer a cardiac MRI as the next line of investigation. And also, even if it is available, it might not be that helpful when it comes to making the diagnosis of what type of amyloidosis, because the type of amyloidosis will decide what we are going to do in the management. And then abdominal fat pad biopsy, good. Majority have voted, and rectal biopsy 3.5%, and renal biopsy. And no one is going to do an endomyocardial biopsy, although there is evidence of significant cardiac involvement. Agree. Because the cardiologist would never agree to do such biopsy at this instance. And the second thing is it's an invasive procedure. And then, we try to get the diagnosis by least invasive procedure in clinical practice. Right. Okay. So we will see the results. Right, so we first did the abdominal fat aspirate and it was negative. We were not surprised. And then actually we proceeded to rectal biopsy, which was again negative for amyloidosis. And then we had to persuade our nephrologist to do a renal biopsy because there was clinical involvement of the kidney. So theoretically there is a high chance that we might catch amyloid deposits in the kidney, but renal biopsy also negative. Then what to do? So is it not amyloidosis, or is it something else? Right, so that brings me to the next question that I'm going to ask from you. Right, so we have done a rectal biopsy, we have done a fat pad aspirate, we have done a renal biopsy, all telling that this is not amyloidosis. So then what is the investigation that is going to help in confirming the possible diagnosis? Are you going to do endomyocardial biopsy at this point? Or are you going to again go for a cardiac MRI to characterize the restrictive physiology? Who is going to do a bone marrow biopsy for a plasma cell clone? Or you think something else is going on? It can't be amyloidosis. We thought that all biopsies are negative. So shall we do a CT cap to see whether there is anything else going on, like a infiltrative or a malignant disease, which can again explain the very symptoms that our patient had. Right, let's see how the vote is. Right, okay, so majority want to do a CT cap to look for something else, something infiltrative, looking at the other organs, and around 30% will go for a bone marrow, and equal percentage, 10% will do a cardiac MRI, and will go for endomyocardial biopsy. Right, again the same principle that you suspect amyloidosis, there is a high suspicion in this patient's presentation and with the examination. So first we consider doing a bone marrow biopsy because of two reasons. One thing is here we are thinking about possible AL type amyloidosis. So if you do a bone marrow, it will give two answers. Sometimes we may be lucky enough to see the Congo red stain in the amyloids in the bone marrow aspirate, as well as we might be able to find a plasma cell clone that helps to type the amyloidosis, right? So we did a bone marrow biopsy for this patient first, and again, bone marrow, there were no clonal plasma cells in the marrow. Bone marrow was negative. And then it's not only SP, we did a serum protein electrophoresis and a urine protein electrophoresis, and there was no monoclonal bands. So we were lost. The history is very suggestive of amyloidosis, as you all appreciated. The examination is pointing towards amyloidosis, but most of the tissues that we are harvesting are going to be negative for amyloid. And then the bone marrow and the serum protein and urine protein electrophoresis, they were all negative for amyloid. So does that exclude AL amyloidosis? That's my question. Right, so we'll move to the last question. Given the likely diagnosis of amyloid, what should be the next best investigation that will aid in the immediate management of this patient? So we have a free light chain assay, we have genetic testing for transthyretin because ATTR is another type of amyloidosis, and the whole body CT scan to look for occult malignancy, repeat bone marrow biopsy because it may not be a very representative sample that we have done earlier. So we do a repeat bone marrow and do a PET CT. What would you think? Yes, so the majority have voted for serum light chain assay. With the time, I will quickly go to the next slide. So yes, so this is your answer. We did a free light chain assay, and the free light chain ratio was 110. And normal kappa lambda ratio is between 0.2 to 1.65. There's a highly skewed, very high free light chain ratio. So then the cardiac involvement and abnormal light chain ratio strongly suggestive of AL amyloidosis. So we made the primary diagnosis as AL light chain amyloidosis with cardiac involvement. And then I'm going to show you the next slide. And this slide doesn't make me happy, right? So it confirms your diagnosis. And unfortunately, you may not be able to see this very clearly because I didn't include any slides taken from the internet. These are the patient's very authentic slides. And this is the normal staining of the endomyocardium. And this is under the polarized light. And if you are lucky, you might see, I can see it here very clearly. There are areas of apple green patches. There's one here. I'm sorry about the, right. Okay, at least just assume that there is beautiful apple green color here and there in the, right, okay. Good job, Nalina. Yes, thank you. So you can see the apple green birefringence under the polarized light. And so this confirmed the cardiac involvement with AL amyloidosis. So the reason I'm not happy is that this was a post-mortem sample. This patient suffered VT, and then it degenerated into a VF, and then he had a asystolic arrest. Despite almost 1 hour of resuscitation, he could not be resuscitated. So he had a severe cardiac involvement, severe cardiac infiltration with amyloid, and he succumbed to the disease. Right, so then before moving to the take-home messages, I just want to focus on the tests and the sensitivity, because in this patient, we did a fat aspirate, we did a renal biopsy, we did a rectal biopsy, we did a bone marrow. None of them were positive for amyloid, but only the endomyocardial biopsy became positive for amyloidosis. Fat aspirate is not that sensitive, it's up to 70%. Renal biopsy, strangely, it is sensitive, more than 90% if the kidneys are clinically involved. But sometimes there can be sampling error, because in our patient, they had only 3 or 4 glomeruli in the renal biopsy. And the second thing is amyloid depositions can be patchy. So there may be areas where there is no amyloid when you're looking under the microscope. And then there can be suboptimal congruent staining. And the rectal biopsy is a good alternative, but sensitivity 70%. Bone marrow is not that sensitive, but additionally, it helps to detect a plasma cell clone. An endomyocardial biopsy, some books tell it's 100% sensitive and it's the gold standard, but not the first line to diagnose amyloidosis. So coming to last few slides, the first thing is you need to recognize early and you need to act fast. Because restrictive cardiomyopathy due to amyloid is often underdiagnosed. It mimics heart failure with preserved ejection fraction, other causes of restrictive cardiomyopathy, hypertrophic heart disease. But when we delay the diagnosis and the treatment, it causes irreversible cardiac damage, as what happened to our patient. So the early detection is the key for disease-modifying therapy. So from suspicion to confirmation, you need to suspect, right? Any patient with neuropathy, proteinuria, macroglossia, orthostatic hypotension, carpal tunnel syndrome, all these are clues. And then you do the echo, you find the heart failure with preserved ejection fraction, with thick LV walls, but no hypertension. There's no aortic stenosis. Think about this. And then you compare the ECG voltage, the low voltage in the ECG versus the left ventricular mass. Think about this. And then the most important thing is confirmation of the subtype, because that is what dictates what are you going to do for this patient. So for AL, urine and serum immunofixation with free light chains, and ATTR amyloidosis, we have all sort of nuclear scans, and we exclude a monoclonal protein. So you need to treat early because it's really changed the outcome. So for AL amyloidosis, urgent hematology referral, we need a multidisciplinary team. The goal is to suppress light chains as fast as we can. So we have chemo, we have, if the patient is fit, we can go for a stem cell transplant. So there's a lot of things, but as internist, so our task is to suspect amyloidosis, confirm it, and to get the relevant teams involved in further management of this patient. So I'm not going to discuss in detail about the management because that is not my expertise, And I think that is not expected also. And then for ATTR amyloidosis, again, there are various medications which modify the disease course, tafamidis and other medications, and there are certain gene silencing therapies available. So to do all these things, you need to know what subtype of amyloidosis you are dealing with. And then as internists, we first do no harm, right? So you have a patient who is symptomatically having heart failure, but your conventional heart failure medications, the medications that we talk that improves prognosis, are going to be harmful at times in amyloidosis, right? Because in amyloidosis, they have a restrictive physiology. They are generally hypotensive, and then they have autonomic dysfunction, and they are very fluid sensitive. So given all these reasons, your ACE inhibitors, your ARBs are going to have some issues with the patient's blood pressure. They have a negative ionotrophy, so your beta blockers are not going to be very helpful. Same as with calcium channel blocker and digoxin. So it's not the conventional medications that we use. Diuretics for the mainstay of congestion and arrhythmia management, you need to anticoagulate if the patient is in AF despite of CHADVASC. And then if there is a conduction disease, consider a pacemaker. So coming to the last slide of my presentation, the practical takeaways. So when you think of amyloidosis, first rule out AL amyloidosis because it is a medical emergency. You can really change the outcome and let the thing that happened to our patient not happen to the next patient. And a negative biopsy does not exclude amyloidosis, so don't give up. Your biopsies will come as negative. If fat aspirity is negative, then it's not amyloid, I have to think something else. No, it's not the case. And the conventional heart failure medications are often harmful. That's what we discussed. And early recognition therapy, early recognition and treatment dramatically improves the outcomes. And in this sort of a patient, we need to have a multidisciplinary care. So that brings to the end of my presentation, and thank you very much once again, and thank you for your patient listening.
Thank you so much, Chamber, for your early morning thought-provoking case-based discussion on this amyloidosis. Shall we sit here? And I would like to invite next presenter, Dr. Pamudita Madanayaka, consultant physician, National Hospital Gold, to discuss about the next segment of the interactive case-based discussion. Pamudita, over to you.
Thank you very much for the kind introduction. And of course, it's my great pleasure to share this session with Chamara, my former co-registrar. So this case, I'm going to name this as paradox of blocking and braking. I hope at least the picture here will do justice for the theme of this session, Young Physician's Lens. So my patient is Mrs. K.S. She's 28-year-old, mother of one, a housewife from Gaul. She presents with 5 days of breathlessness. It was acute onset and progressive since then, associated with left-sided pleuritic chest pain. No evidence of fever, no evidence of infection, no evidence of heart failure in the history. There was no hemoptysis, no calf pain or swelling, and no recent immobilization. The past history was only significant for pregnancy-induced hypertension. Examination, the saturation was 98% on room air, blood pressure 110/70. She was tachycardic at 104 with a respiratory rate of 30. Rest of the examination was unremarkable. So, we are going to go again with some questions, and I think this will be very easy. What is going through your mind? Pulmonary embolism, pneumothorax, or community-acquired pneumonia with a possible or pleural infection? Right, let's see the results. Right, so there's a very good response rate for pulmonary embolism, and some people do think it could be pneumothorax, fair enough, and also it's still possible to have a chest infection. Right, we'll go back to our patient and we'll give some more details. So investigations, the basic investigation, there's a neutrophil leukocytosis with marginally low platelets. There's a raised CRP, a slightly raised APTT, and a high protein. Renal and liver functions were normal. ECG shows sinus tachycardia, and the chest X-ray, there was no obvious abnormality. So I think now we are pointing towards a possible pulmonary emboli. So what would be the next investigation? So I'm going to give you some options and describe why I'm giving these options so you can vote. It will be easier for you. A CTPA that can confirm a pulmonary emboli. A VQ scan if you're worried about radiation in a young female that again can diagnose a pulmonary emboli. A D-dimer, if it's negative in some instances, we can rule out pulmonary emboli. A lower limb venous Doppler, if positive, we might very well treat for thromboembolism without needing for further scans. Or a 2D echo, which can look for evidence for pulmonary emboli, and also it will look for other causes as well. So what is your preferred next investigation? Let's have a vote. Yeah, let's see the results. Great, so most of you think it's CTPA should be the next investigation, but there are people who think other investigation will also help. Let's move on with our patient then. So we did a well score, which also helps in deciding what would be the next step. So in the well score, this patient has scored 4.5 because his PE is, we think, is the #1 or equally likely #1 cause for these symptoms, and there's tachycardia. So well score more than 4, we have to go for imaging, and if it was 4 or less, we can do a D-dimer and rule out PE. So we need to go for imaging now. Which imaging is better here, provided we had both imaging freely available? So CTPA versus VQ scan at this stage. VQ scan, it has less radiation to the breast tissue than CTPA. There is no risk of contrast nephropathy or allergy. But the problem is it's not ideal and it's non-conclusive if there's lung disease. On the other hand, CTPA directly visualize the clot and also can see the right ventricular involvement, which is important in some management decisions. And also, if it's negative for PE, we can still go for a diagnosis from the CTPA. So it's useful in that context as well. There's no rule as such, but what's the accepted way, considering the irradiation in young women, if the chest X-ray is normal and the patient is stable, and if VQ scan is available at hand, we go for VQ scan. But if there is known lung disease, or if there's an abnormal chest X-ray, or if the patient is unstable, may require further invasive treatment, then a CTPA is the ideal investigation. But of course, if we don't have the VQ scan, we definitely go for CTPA. I'm going to just move away a bit from this patient for a moment and go for another question. Suspected PE in pregnancy. what are you going to do? We know that D-dimer is not that useful in pregnancy, so we have to go for an imaging. Will you do a CTPA? Will you do a VQ scan? Or will do neither of them and think about something else? Let's go for another vote. Right, few more people to vote. We could probably see the results now. Yes, so majority of you very correctly thinks we should go for a VQ scan. I'm just going to give a few tips on radiation, especially in pregnancy, before coming back to our patient. So for the fetus, if you're worried about radiation to the fetus, both CTPA and VQ has very low radiation to the fetus. And if you take a chest X-ray, it's negligible. In all three trimesters, the radiation from chest X-ray is negligible. So there's no teratogenic risk or miscarriage risk in any of this investigation. There's no risk for the fetus. Just to mention about the values, it's 50 milligray is the teratogenic threshold, and chest X-ray is like standing in the sunlight for 10 minutes. It's no difference. So we can always go for imaging if we are worried about the fetus. The problem here would be the mother. For the mother, there's increased breast circulation at pregnancy, so the risk of radiation is more. So CTPA has a higher risk compared to the VQ scan. So as you very correctly said, we should do a VQ scan. So the point is, even if it's pregnant, the investigation line would be the same. If chest X-ray normal, VQ scan. If the chest X-ray is abnormal, we go for a CTPA. Because diagnosing and treating the mother's condition will have more effect to the fetus than any radiation risk of any of these imaging techniques. Right, back to our patient. So we got some investigations back. So we had to do a CTPA because VQ scan was not available. And there are bilateral main pulmonary artery hypodensities suggestive of pulmonary emboli. And we did a lower limb Doppler as well. We showed extensive DVT in spite of patient not having any clinical evidence of DVT. And this was the 2D echocardiogram from the patient. I want you to concentrate on the apex and the right ventricle here. So this is a specific sign in pulmonary emboli, so which is called a McConnell sign. So because of the sudden increase in pulmonary artery pressures, the right ventricle contraction is impaired. So there's akinesia of the free mid-wall on the side. But because the apex is tethered to the left ventricular apex, they move simultaneously. So you get the hyperkinetic apex with the hypokinetic free right ventricular free wall. And also you can appreciate the right atrial and right ventricular dilatation with a normal left ejection fraction, normal left ventricular function. So just to go through that again, so the apex is moving normally while the free right ventricular wall is hypokinetic, which has a very good specificity for pulmonary emboli. So the management in this patient, hemodynamically stable, not a massive PE, so not for thrombolysis. Right ventricular strain and myocardial injury was present. So we consider this is a submassive PE. So we can consider mechanical thrombectomy if patient is deteriorating or if it is easily feasible on the CTPA results. But otherwise, in our setting, we started her on anticoagulation. So what's the underlying pathology here? So patient has PE, mild thrombocytopenia, and prolonged APTT. I'm not going to go for a vote because the answer is obvious. So this was antiphospholipid syndrome. So we started investigating for that. Anticardiolipin, IgG positive. Anti-beta-2 glycoprotein, IgG positive. Lupus anticoagulant, we have to wait for at least 3 months to do this after the thrombotic event, so we haven't done it yet. And ideally, patient should be off anticoagulation. So we have to come to a stage where it's safe to stop anticoagulation to proceed with lupus anticoagulant. But it is important to do that later because of, I'll tell you why later. So even with these results, we can diagnose antiphospholipid syndrome. There is one clinical criteria and one laboratory criteria already fulfilled for that. So predictors of thrombosis, that's why it's important to check for lupus anticoagulant. So if it's positive, it's the strongest predictor for future thrombosis out of the 3 tests. But if all 3 are positive, that is triple positive APLS, it has the highest risk of thrombosis. When we compare IgG and IgM antibodies, IgG has a higher risk of thrombosis than IgM, and any antibody, the higher the titer, higher risk of thrombosis. Fine, then we'll move on to the management of this patient. So what are going to start for him, this patient? Warfarin with enoxaparin bridging, or just go with enoxaparin only? Unfractionated heparin, or direct oral anticoagulants, the newer drugs? So we'll go for a vote again. What would you start for this patient? We'll look at the results. Yes, warfarin with enoxaparin bridging. Most of you have gone for that option. So there is some evidence for this. So there is some studies like the TRAPS trial, which compared rivaroxaban against warfarin in triple positive APLS. And rivaroxaban was inferior to warfarin in this study. So currently, warfarin should be started for anyone with triple positive APLS, arterial thrombosis, or recurrent VTI. But it's good practice to give warfarin in APLS and not to start DOAC because we don't have much evidence for DOAC in APLS. So the patient was started on warfarin and enoxaparin as bridging therapy. And we thought we've solved the case. On day 7, but there is a U-turn. Patient started getting fevers, generalized weakness. She was getting progressively more breathless. She was pale and there was tinge of icterus. There was no bleeding manifestations. We got some investigations. Now the full blood count, there's anemia and severe thrombocytopenia. The inflammatory markers have gone up. The renal functions remain normal and the AST-ALT remain normal. Further investigations, there's indirect hyperbilirubinemia with a raised LDH. I'm going to give you the blood picture as well before going for a vote. So it's normocytic, normochromic RBC, no fragments, few polychromatic cells, and few spherocytes. Mild neutrophil leukocytosis, there's thrombocytopenia with large platelets. The retic index was increased. Fine. What is the diagnosis here? I'm going to give some differential diagnosis so you can vote. Is it catastrophic APLS? Evans syndrome with APLS? Is this evolving SLE? Or is this sepsis and DIC in the patient with the PE? And we started enoxaparin. Could this be heparin-induced thrombocytopenia? Or maybe it's something else. So we'll go for a vote again and see what you think is going on now. Right. So 43% think it's Evans syndrome with APLS and 20% catastrophic APLS. Evolving SLE, 22%, good. So there are still, it's not resolved, isn't it? It's not solved. There's still things we need to look for. So we did the ANA panel. ANA panel was negative. The microbiology, HIV, Hep C, EBV, CMV negative, mycoplasma was negative, and blood cultures remained sterile. We did the direct antiglobulin test, the Coombe test, and it was IgG negative, C3D positive. That's like a cold type autoimmune hemolytic anemia. Right, so we'll just have a quick, we'll go through the main differential diagnosis and see whether they fit into this case scenario. So catastrophic APLS is a rapidly progressive multi-system disease where widespread microangiopathy, thrombosis in the microangiopathy, and it occurs in APLS. It's very rare but has a very high mortality. The criteria for diagnosis, 3 or more organ involvement, which we didn't have. Development within 1 week, which is there in our patient. There should be histopathological evidence of small vessel occlusion without vasculitis, because that will be the other differential diagnosis. We haven't done a biopsy here, so we don't have it yet. And confirmation of APLS, which is there in our patient, but we haven't got all the criteria. Evans syndrome is the autoimmune hemolytic anemia and immune thrombocytopenia, with or without autoimmune neutropenia. So it can be either primary or secondary, and interestingly, it can be secondary to APLS as well. But the thing here is, it's usually IgG mediated. It's usually warm type autoimmune hemolytic anemia, and that is positive for IgG, which wasn't there in our patient. Evolving SLE, again, the ANA was negative. There was no criteria to diagnose SLE. And sepsis with DIC we have excluded with the cultures and the blood picture. Heparin-induced thrombocytopenia, the time frame is correct. It can happen with low molecular weight heparin, but it will not explain the anemia. So likely diagnosis here is Evans syndrome variant secondary to APLS, because it's a cold type autoimmune hemolytic anemia. So there's evidence of autoimmune hemolysis with thrombocytopenia and with APLS, no DIC. That is positive for C3D, not negative for IgG, and the ANA was negative. So we managed this patient with 6 cycles of therapeutic plasma exchange and methylprednisolone, but patient finally recovered well after rituximab, which reduces the beta cell, which is the reason for the complement activation and all the pathophysiology behind the clinical condition. So the practical takeaways are, one is use of pre-test probability scores in evaluating PE is helpful to decide whether to go for D-dimers or imaging. Use of imaging in young women, we have to be careful about the breast radiation, but also in pregnancy. But important thing is there's minimal fetal risk of our imaging techniques, so don't worry about fetal radiation. Do what is best for the mother. Look out for rare complications and start treatment early, like the plasma exchange we nowadays have to do often in many clinical scenarios. And of course, the importance of multidisciplinary care. This patient was managed with a lot of other subspecialties, as it was involving multiple systems. So thank you very much for your patience listening.
Thank you, Dr. Pramaditha. Can you come to the seat? So it's a very interesting case we see in medical wards. Now we have around 2 minutes left. As in a symposia, we will open the audience for questions.
Congratulations for putting up such an excellent patient stories and discussion. I I have a question to Chamara. What was the reason for you to analyze the pleural fluid where he had the both sides, no? It was bilateral. I thought from the beginning it would be a transudate. Was there any particular reason to analyze the pleural fluid?
Yes, so because of the inflammatory markers were elevated, and then there was asymmetry, like there was a moderate right-sided pleural effusion with a mild, very thin left-sided pleural effusion. So we had one of our differential diagnoses was on tuberculosis as well. So with that context, we wanted to see whether it's an exudate or a transudate. And the second thing is to do some microbiological studies on tuberculosis on the pleural fluid.
Thank you.
In the absence of further questions, we will conclude the successful segment of the interactive case-based discussion. Now I would invite my co-chair, Dr. Nandan Ikmazuka, to hand over the certificate of association on behalf of the Sri Lanka College of Internal Medicine. First, Prof. Chamara Dalugama. Next, Dr. Pamuthu Madanayaka. Thank you.